This week on the BackTable podcast.
Yeah, so currently, based on the FDA approval, it's only patients that have HR alterations that are eligible for PARP inhibitors, period, whether it's monotherapy or a combination. I think the data is compelling that in this trial population, this combination is synergistic. But the tricky part in applying it to our patients in clinic is that most of these patients in the HSPC setting received ADT monotherapy. Only 5% of patients received ABI. No patients received a prior AR therapy, whether it's Enza, APA, or Daro. 20% actually had docetaxel, but for the most part, they were ADT monotherapy patients.
Good morning. My name is Bogdana Schmidt. I'm a urologic oncologist at the University of Utah, the Huntsman Cancer Institute, and it is my pleasure to have with me today Dr. Shilpa Gupta, director of the GU Medical Oncology at the Taussig Cancer Institute and co-leader of the GU Oncology program at the Cleveland Clinic, and Dr. Benjamin Maughan, associate professor in medical oncology from University of Utah, Huntsman Cancer Center, someone I get the privilege to work with frequently, on with me today to discuss GU ASCO 2025.
Thanks so much for having me. It's wonderful to be here with both of you.
Thank you. Same here. Really delighted to be with you here.
Wonderful. Well, I thought this was a great GU 2025. I'm excited to get into it. I want us to have a chance to talk about a few different things this morning. So let's start with a couple interesting presentations in prostate, then bladder, and we'll finish up on kidney cancers. If we have time, we'll talk about testis cancer as well, but we'll see how this discussion pans out. So this is likely a surgeon-heavy audience for us. So let's talk a little bit about the trials presented by Dr. Roy in prostate cancer, looking at radical prostatectomy and radiotherapy in high-risk prostate cancer. He effectively took two trials, the PUNCH trial and RTOGO521, and looked at a high-risk prostate cancer population and used the data from these two trials to talk about disease-free survival or metastasis risk in those patients. So obviously, this is not randomized evidence in the same way, right? This is not SPCG 15 that we're all waiting for. But at the same time, this is data that we can use to potentially counsel our patients on how we approach high-risk prostate cancer in this population. So for the most part, these are patients, right, had localized disease on conventional imaging, CT bone scan, who had PSA elevations, but under 100. So we are assuming localized, maybe micrometastatic, now that we know what PSMA offers in this space, and offering them RT plus long-term ADT versus surgery, looking out to about 6 to 8 years, I think, based on these two trials. So Ben, what do you think about the findings that Dr. Roy discussed?
Yeah, it was pretty intriguing. Obviously, it's not a direct randomized comparison, but they were both done relatively contemporaneously, and they're both large studies, right? So each of these in its own is a randomized study, and the randomization was similar between these two trials. It was, standard of care at that time with or without 6 cycles of adjuvant docetaxel. So in my opinion, they did a really good job of trying to compare both of these data sets, right? They compared the overall outcomes from one trial to the next in terms of disease-free survival, but then they also did subgroup analysis looking at the standard of care arms in each directly compared across versus the experimental arms. So then you could get an assessment of, is there some docetaxel interaction that's affecting each of these trials? In both of these trials, it's important to note that the standard of care was preferred over the experimental arm, right? We don't routinely give 6 cycles of adjuvant docetaxel after definitive radiation nor after radical prostatectomy.
I should just say that I led you into this discussion, but I forgot to say what the findings were. We're sort of holding the punchline here. So what he presented was that the radical prostatectomy group had distant metastasis rates at about 23% versus 16% in the radiotherapy arm, so favoring radiotherapy. So I want to make sure that your discussion is in this context for the group.
I was about to make that point that definitely the findings that they found support that there's a longer distant-free metastasis interval with radiation compared to surgery. And it was a long follow-up time, as you mentioned, 8 years, for both studies, but I'm not totally convinced that it really answered that question. Because if you look at the treatment, we know that, in the RTOG study, they got 2 years of ADT. And we know that that's very effective in preventing metastasis. They don't mention what the median duration of ADT exposure was in the surgery arm, or I'd say hormone therapy. Presumably, a number of those patients went on to either concurrent bicalutamide or concurrent ADT when they got their, for the patients that did, when they got their salvage radiation therapy or adjuvant, whichever was employed for that specific patient. And if you look at the Kaplan-Meier curves for disease-free survival, it looks very parallel to me. There's like an offset of a couple of years where there's like
2-year offset of ADT?
Yes. So like there's no metastases occurring in the RTOG, arm of this comparison. And then it starts having some patients with metastasis. Whereas with surgery, it's you start from time 0 starting to have some metastasis, but they remain very parallel. So to me, it doesn't really, it reinforces what I would say is the overall body of evidence that when we're looking at populations, there's not a measurable cure rate difference between surgery and radiation, even in this high-risk group, is what I would take away from this. Interestingly, though, if you look at the subset analysis of mortality, there was a lower rate of cancer-specific mortality in the RTOG arm, slightly, but that was offset with a greater percentage of non-cancer-specific mortality.
Right. That was pretty significant. It was about 1% in the surgery arm and 11% in the radiotherapy arm. Now, I think that speaks a little bit to the difference maybe in the cohorts. There's slightly older patients, I thought, in the radiation arm. If you balance them out over more patients over 70.
66 years for the two studies.
In the median, yes, but just the numbers, I think there were more numbers over age 70 in the radiation arms. But still, I agree with you. That's a significant factor to consider how this impacts the way we interpret this.
So for me, I guess the takeaway is this really supports both radiation and surgery in this population. Very much different than the dogma that was sort of still holding out at the time when I was in residency and early on in fellowship of high-risk disease is just radiation and ADT.
Hormones. Yeah. And I think randomized data in the SBCG 15 trial will give us that information more directly.
Well, eventually.
Yeah.
But what this data
and then it'll
really
be irrelevant, right? By the time we get a prostate cancer data trial, we will be operating differently and treating differently. And then we'll say this data would have been great 5 years ago.
Yeah.
Good. My takeaway was similar to yours, actually, that this did not, for me, say surgery is the wrong approach for these patients. I think we still need to be thoughtful. I think we still need to be selective. I think we still need to be tracking how these patients do, whether it's obviously through randomized data that we'll get, but also through some of the prospective registries that we have in this, and trying to figure out plans more individually targeted to the patient, to their quality of life goals, their disease-specific goals, and not necessarily saying one is an option, the other one isn't, but trying to fit the patient's disease into the landscape and be more directed and tailored to it.
I will say one last comment, though. Interestingly, when they did the comparison of just the patients in each trial that received docetaxel, they didn't see any difference with metastasis-free survival. So again, that suggests to me that both options are equally successful in curing patients that truly have localized disease. And systemic therapy is important if you have metastatic disease.
Absolutely. Now, speaking of systemic therapy, I want to segue towards TALAPRO-2. So this was a phase 3 trial that compared talazoparib plus enzalutamide versus placebo plus enzalutamide in the first-line metastatic castration-resistant prostate cancer. Now, this trial previously met its primary endpoint and had an FDA approval of talazoparib plus enzalutamide for patients in the metastatic castrate-resistant population with homologous recombination repair, or HRR, deficiency. So what was different about this presentation at GU ASCO 2025?
Yeah, so this actually gets to be a pretty complex discussion. So I'll do my best to just be simple here and just hit the highlights. But there were actually two reports of the TALIPRO-2 trial. One was an oral presentation by Dr. Niraj Agarwal, and the other was a poster. The poster was showing long-term results for the population of patients that had alterations in homologous recombination repair, like BRCA mutations, ATM, PALB2, whatever. What we saw earlier, which led to the FDA approval, is that this population of patients dramatically benefited from the addition of talazoparib, a PARP inhibitor. That's what you would expect. The intriguing and controversial findings are what was presented in the oral session by Dr. Niraj Agarwal. The nomenclature gets a little tricky here. In the presentation, they described it as unselected patients. So to be clear, that doesn't mean all the patients in the study. The unselected population that was presented is specifically those patients that had wild type or they were HRR proficient. There were no mutations that were observed on their testing.
So BRCA negative patients.
Yeah, so BRCA negative. And the hypothesis for TALIPRO-2 is that this particular combination will work synergistically. So even if you're BRCA negative, even if you're HRR proficient, right, you're wild type, you're going to benefit. This will sensitize you to a PARP inhibitor. Whereas in the past, lots of single-arm studies with just PARP inhibitors show that if you have wild type, if you're proficient, however you want to define that, you do not benefit from PARP inhibitors. So this was the controversial data. And I think it was quite compelling for demonstrating or supporting the hypothesis that synergy is seen, right? So in this unselected population, in this BRCA negative population, there was a significant improvement, not only in radiographic PFS, but in terms of overall survival. And they did something else that was, at least for me, particularly compelling. So to be enrolled in this study, you had to have tissue testing, right? So most of this was prostate biopsy, prostatectomy. A couple of them were metastasis at the time of enrollment. But that is tissue from presumably years ago. So they also had a population of patients, about 15%, that had, at the time of enrollment, liquid biopsy testing, ctDNA testing performed. So they looked at this 15% of the patients that had both negative testing on the original tumor and negative ctDNA testing, right? To be as thorough as possible to say you are a wild type population. And they also saw a significant improvement in overall survival in this smaller cohort, right? So it's really strongly arguing that enzalutamide is inducing a synergistic effect with talazoparib. So you can use it for everybody is really what the data is showing us, which is really quite compelling and counterintuitive from what we were expecting the results to be.
Especially in the PARP only trials, right? Because that's our experience that we saw using PARP in the neoadjuvant setting even. But this is interesting. I mean, to me, this is obviously very interesting to see how this will play out, especially in patients who have already received something like enzalutamide or abiraterone in the hormone-sensitive setting. Shilpa or Ben, what do you guys think about that? Do you think this will change how it's used in the castrate-resistant setting, or to be determined?
Yeah, I have a question, Ben. So in this study, there were two cohorts, right? There was cohort 1, which was the unselected. Was that all HRR negative patients, or was that the all comers, regardless of the HRR mutations?
Yeah, so it, like I said, this trial gets very confusing once you start trying to follow the nomenclature. But
that's why we have you two.
The cohort 1 was the unselected patient population, was the BRCA negative population. I hate to say BRCA because there were like a total of 12 genes that you could have altered that made you eligible for cohort 2. But cohort 2 is the DNA mutated population, whether it was mutations in ATM, BRCA, RAD51C, PALB2, etc., FANC-A. Cohort 1, the unselected population, are those patients that tested negative for these mutations. But I agree, the nomenclature is weird when you say unselected. It sounds like the entire...
all comers, yeah. I think, to my take is that when we look at the data from the other trials too, putting everything in totality with all the progress we've made for the genomic testing and precision medicine, I think the data is more compelling for patients with HRR alterations. And whether it will get an approval for all comers remains to be seen. But would love to hear, Ben, are you going to change your practice and use it for everybody or just with HRR alterations? Currently, I'm using it for patients only with HRR alterations, not just BRCA.
Yeah, so currently, based on the FDA approval, it's only patients that have HRR alterations that are eligible for PARP inhibitors, period, whether it's monotherapy or a combination. The tricky thing when we try to apply this, I think the data is compelling that in this trial population, this combination is synergistic. But the tricky part in applying it to our patients in clinic is that most of these patients in the HSPC setting received ADT monotherapy. Only 5% of patients received ABI. No patients received a prior AR therapy, whether it's ENZA, APA, or DARO. 20% actually had docetaxel, but for the most part, they were ADT monotherapy patients. So even if this is synergistic with talazoparib, is it synergistic after they've been exposed to ARPIs or not? That's tricky and difficult to know. I will say the way I approach it in general is that I use this data in terms of helping me understand the sequence of treatment. So if they have an HRR alteration, certainly I try to, especially BRCA2, I try to sequence PARP inhibitors as soon as I can in the CRPC setting. And this data strongly supports that too. If they have some other alteration like ATM or whatever, then I will expose them to a PARP inhibitor, but it'll be later on in the treatment sequence. So really the question becomes, what do I do about the population of patients that have wild type that are this, quote, unselected? I think if it's FDA approved, I think I will use it. The question is going to be where in that sequence do I use it? Considering it's not chemotherapy, it wasn't particularly toxic, with the exception of anemia. We can talk about that separately if you want. I think I would likely try and sequence it early. It certainly doesn't seem to have the same lasting long-term consequences that patients have with docetaxel. In terms of the neuropathy, their just performance status never seems to fully recover in my experience. So
you mentioned anemia. I think these patients were more likely to receive blood transfusions, right? That's what they demonstrated on trial.
Yeah, that's correct. The anemia rate was very high in this study. So this was a placebo-controlled trial. So if you look at the grade 3-4 anemia rates in the placebo arm, it was something like 5 or 8%. So really low. Remember, this is a trial population, so it excluded people that had severe anemia to begin with. But in the talazoparib arm, it was something like 65%. So it was really high.
Yeah, I would say that even though, chemo has a bad rep historically, like when given the right way, it's manageable. And just for our audience out there, sometimes when patients are on these oral PARP inhibitors and, if we are not monitoring them closely, they can, crash pretty quickly. So they do require weekly labs and everything and check-ins, because I've seen patients, their hemoglobin drops down to 5 and, you just have to keep a very close eye, and it's very important to manage the anemia proactively.
But I will say this fits with the recently published data from Maha Hussein from the BRCA trial. That was a much smaller study, but 3-way randomization between olaparib monotherapy in the CRPC setting, olaparib monotherapy, ABI monotherapy, or the combination. And patients were allowed to go on to olaparib and ABI. You could cross over to monotherapy with the other arm. But we saw dramatically better benefits with patients starting with olaparib plus ABI. It was 39 months versus those patients that received them sequentially. So there's this growing data that these combinations appear to be synergistic.
Yeah, no, I think that's really interesting. And I think, Shilpa, to your point, yes, even in this trial, we saw that there was a more pronounced benefit in patients who do have the HRR alterations. But the fact that we're seeing a benefit in patients who don't is really interesting to see where this will fall in the landscape of their care among the other options. So remains to be seen, but very exciting to have this data. Let's transition a little bit towards bladder cancer. And there was quite a bit of interesting discussion about IO combinations, looking at immunotherapy in the muscle-invasive bladder cancer, in upper tract, even in non-muscle invasive bladder. So we'll focus on that whole concept a little bit today, discussing the bladder presentations that we had. And Shilpa, I want to start talking to you about the disitamab vedotin, the HER2 antibody drug conjugate presentation that was made for muscle-invasive disease in combination with toripalimab, the anti-PD-1 inhibitor. So can you tell us a little bit about that trial and what the main takeaways were?
Yeah, absolutely. So this trial came out of our Chinese colleague study that was presented. So there were 47 patients who were enrolled who, could have clinical T2 to T4, N0, N1 disease, and they needed to have HER2 positive expression in their tumors, could be plus 1 plus, 2 plus, or 3 plus. And patients were all planned for curative intent cystectomy and pelvic node dissection. They received disitamab vedotin, which is a HER2 targeting ADT, and the toripalimab, which is available in China, every 2 weeks for 6 cycles. And after the surgery, patients also received adjuvant immunotherapy for up to 20 cycles. Primary endpoint was pathologic complete response. And, in this, first of all, talking about the HER2 prevalence in this patient population, 10% had HER2 IHC 1 plus expression, over 50% had 2 plus, and about a third had 3 plus. And so, the surgery was performed in 33 patients only. So that is a key thing that, as our audience will appreciate, not everybody made it to surgery. 70% patients got to the surgery, and median time from end of neoadjuvant treatment to surgery was about 5 weeks, which is pretty good.
Pretty short, actually.
Yeah, pretty short. Yeah. The pathologic complete response was 63%, but the caveat is that they only included the denominator, for patients who underwent surgery. But typically in these studies, the intention to treat patient population needs to be in the denominator. So if we were to go by every other study that has been done out there, it's actually much lower. So we don't want to be, quoting a very high number, because if somebody got neoadjuvant treatment and did not make it to surgery, that's an event, right? That's something that we don't want to happen. So overall, I think the data, my take on this is that, yeah, it's exciting. We are moving towards all these ADCs, and HER2 has again emerged with a great interest. But toxicity was also not minimal. The Clavien Dindo post-op complication rate was 15%. And the most common surgical complication apparently was stoma infection.
Stoma infection, which is rare. I mean, I would say as a surgeon, knock on something. I've never seen that.
Yeah.
So it's interesting to me. Was there a different way that they defined it? Was there something surgically that they're doing or not doing that we do routinely here? Because surgical wound infection is something we talk about sometimes, especially with patients with high risk factors, like diabetes, obesity, all of these things that we know lead to wound infections. But stoma infection was something that surprised me very much.
You don't see that very often, right? So this is also very intriguing that they saw that. And if we were to talk about, the intention to treat patient population, the grade 3 or higher adverse events were seen in about 28% patients, and serious adverse events in about a quarter of patients. 12% patients needed, actually 17% patients needed discontinuation of study treatment. So I think overall, this is not an easy regimen like we are used to with chemotherapy and immunotherapy. And this drug does have the usual toxicities of the ADCs that we see. But I think when they presented the median follow-up data also in this, they reported that 12-month overall survival was 95.5%, which is really not surprising. And the event-free survival was 92%. Now, how they counted the event-free survival is again a topic for discussion, because the lack of making patients get to surgery should be an event. So I think this data is, showing us that these studies are doable, and we'll just have to learn more from future studies.
Completely agree with you. And I do think that, like you said, those patients who don't go on to surgery, we really need to know a lot more about them. If they don't go on to surgery and are going on to do phenomenally and don't need surgery, right? They're disease-free in the bladder, disease-free everywhere else. That's fantastic. That's great. But that's not what this is necessarily showing. And so we definitely need to see more about that. I also think the whole concept of HER2 expression in this population is relatively new to us because routinely when we do a TURBT, even for muscle invasive, that's not something that's reported in standard path reports, right? So this is something that we would have to be, as a community, saying, okay, we need to request this routinely for every patient before we embark on neoadjuvant therapy. And that would be a paradigm shift from where we are today. And certainly if the data were compelling, I think we would all be going into that direction. I think we're all going in that direction slowly anyway, given the number of newer agents that are mutation specific. But this is one of few today, and I don't think we're there yet. And to me, like you, this data is not compelling enough to say that we need to change the way we're treating these patients.
That point's, I think, particularly important because super small numbers, but as I recall, Shilpa, please correct me if I'm wrong, but like when they looked at pathologic CR rates based on IHC staining, again, super small numbers, but you could very easily make this trend towards, like a IHC 3 plus was much more likely to benefit than 1 plus. Whereas when they did the PDL staining, it, as we oftentimes see, didn't show a trend.
Yeah. And also, I think the numbers for IHC expression seem very high to me, because we, as you know, in the US, we have access to TDXD for our metastatic patients. And, for all these patients I'm testing, I'm not seeing this high expression of IHC. I don't know what your experience has been, Ben.
No, I agree with you. And that's actually the questions that were brought up at the end of this talk was if we look at TCGA, we're looking at this expression at under 50%. So how many patients will this actually impact? How many patients whom we're seeing in our population are going to be 3 plus, right? And to find that out, we need to be absolutely routinely testing everybody up front. So I think that remains to be seen how this factors into the landscape. But you're right. I don't think we know what the N is for these H3 patients at this point. And I think this gets in a little bit to what we were talking about with the other trials, right? This concept of combination. So when the INDUCT trial was presented, the 10-center French study looking at neoadjuvant durvalumab in combination with GemCis, I'm transitioning all the way to upper tract right now. But I just think it's interesting to think about the IO chemo combination in this setting. I'm skipping over NIAGARA a little bit, but I also want to talk about it because obviously we saw the initial NIAGARA presentation at ESMO 2024, and we did discuss that with Dr. Apollo this summer on BackTable, but we did have more NIAGARA data to discuss. And then we had INDUCT, which is neoadjuvant durvalumab and GemCis in upper tract. And both of these certainly showed positive signals and worth discussing on how this will impact our landscape. So to start, maybe we'll just give us the NIAGARA highlights, and then we'll transition to INDUCT and upper tract.
Yeah, so like you said, NIAGARA was, the key presentation at ESMO. I think it was very important for a variety of reasons. A large trial, about 1,000 patients. The first phase 3 study shows to show superiority of GemCis and immunotherapy in muscle-invasive bladder cancer. And also a very inclusive trial, way ahead of its time. They included variant subtypes. The creatinine clearance was pretty low for threshold. It was 40 mils per minute as opposed to the historic 60. And we're all comfortable, treating late 40s, 50s with split dose, but this went even lower. So technically, there were some cisplatin ineligible patients in this study too. And they also included node-positive patients. So what was intriguing was the study showed event-free survival benefit and overall survival benefit at the first analysis. And just for our audience, this study was completed over 5 years ago. Then there was no availability or approval of adjuvant nivolumab, even in the US. So I think this study was important for all these reasons. And we have this overall survival improvement regimen. Although, we really don't know what the subsequent therapies were in the control arm. Did they have access to subsequent immunotherapy or antibody drug conjugates, which are life-prolonging? When we saw at ASCO GU here, the event-free survival at 12 months was 76% with GemCis durvalumab versus 70% with just chemo. And at 24 months, it was 67 versus 60%. And they also broke down the overall, there was a 31% reduction in the risk of death from bladder cancer compared to chemo. Now, they specifically looked at the cohort of patients who achieved a pathologic complete response versus who didn't. And in patients who underwent the treatment and achieved pathologic complete response, which was minority, obviously, durvalumab fared better at 92.1% versus 85.8% for event-free survival at 2 years. But in patients with non-pathologic CR2, it did give an advantage of 2-year event-free survival at 53% versus 50%. So I think what we don't understand is that what is the adjuvant portion adding to all this, right? So that will remain a mystery because everybody got this treatment regardless of their PAT-CR status. But I think overall these findings are encouraging, and the fact that immunotherapy is adding to the durability of response, although the pathologic complete responses per se were pretty low in this compared to what we see historically. With just GemCis, it was 27%. With the combination, it was 37%.
But like you said, this included slightly higher risk patients.
Right.
How do we translate that a little bit to the INDUCT trial that was presented? So this was looking at neoadjuvant durvalumab in combination with GemCis, no adjuvant therapy in this cohort discussed for upper tract. So in upper tract, we've had certainly a paucity of randomized data, right? We had the POUT trial looking at adjuvant therapy, and that had a 62 over 45% disease-free survival benefit of adjuvant chemotherapy, GemCis or carbo. And now this is looking at neoadjuvant durvalumab and GemCis or carbo, relatively small, 50 patients. And 5 of these patients ended up switching to carboplatin during the chemotherapy arm, right? So they had a transition from cis to carbo. But they did demonstrate important, I would say, benefit to this treatment regimen. What did you think about that?
Yeah, I thought this was a very progressive study, right? To date, we've not had anything like this in upper tract, and really impressive that they took on this patient population, which kind of gets left behind. So, cohort 1 had 30 patients who got GemCis durvalumab, and cohort 2 had around 19 patients who got carbo gem and durvalumab. And like you said, Bogdana, 5 patients had to switch from GemCis to gem carbo. So the primary endpoint was pathologic complete responses. And they did show that, GemCis resulted in better responses. They were 13% pathologic CR with GemCis durvalumab compared to 5% with gem carbo. But they were, first of all, I think the key aspect of this study is that it's doable, right? There were no new safety signals. Patients were able to undergo surgery. So that's all good things. I think some of the limitations were that there was no control arm with just chemo. So we'll never really know what the immunotherapy added in these patients. Because even today, we don't have any large trial telling us that these patients should undergo neoadjuvant GemCis-based treatment, right? We are just doing it in some patients, or in some patients, we're doing it adjuvantly. We don't really know what is the way to go. And I think there was one other comment that was made that biopsy was not mandatory in this study. Only 50% patients had it. So you could go on based on a urine cytology.
And so the other comment with that is biopsy in this patient population is so challenging. It is so challenging. Our equipment for upper tract biopsy is suboptimal. For every industry person out there listening, please make us something better. And we all know the rates of upstaging in these patients, right? So we often just go off of high grade, low grade because you trust that aspect of it, but the depth of invasion is so hard to tell preoperatively. And you're right, these are patients that were all going on to get a nephroureterectomy anyway. So is PathCR the right endpoint necessarily? I understand that's what we have, but not knowing what the preliminary path was, knowing what unreliable rates of staging we have in the pre-op setting, looking at PathCR rates, I think is a little bit potentially misleading in this patient population because you don't really know what you started with.
So technically, you're looking at clinical staging pre-op and pathologic staging post-op, right? Yeah, I can see how this is challenging.
Exactly. And I do think that certainly right now our paradigm for upper tract is a challenge. We know this is a dangerous disease. We know that our treatments for this are limited. Our ability to give cisplatin-based chemotherapy after nephroureterectomy is quite limited. We know that from POUT that a third of patients weren't eligible to even receive anything. And so giving more in the neoadjuvant setting is intuitive. We all want that. But I think on this trial alone, it's a little bit hard to know what the benefit of the IO addition was in this space.
Yeah, I will say to that point, especially for upper tract, that's why I'm really excited for this ongoing development of ctDNA, because then it's like apples to apples comparison, right? Like, is it detectable and then becomes, undetectable, right? I mean, to my knowledge, you know the data much better than I do, Shilpa, but to my knowledge, we don't have ctDNA specifically in upper tract, but presumably it's going to be similar in terms of like if you transform to undetectable, that's going to be a good thing. But I think it has the potential to really help this issue of difficulty with biopsies.
I agree. And I actually think ctDNA is a really important thing to consider in this space, because right now we often rely on urinary cytology, but one of the challenges with urinary cytology is you don't know where it's coming from in upper tract. Is it coming from an upper tract tumor? Is it coming from a non-muscle invasive tumor in the bladder? Right? There are challenges even using biomarkers in this space that are urinary based. So looking for other alternative will be tremendously useful.
That's a great point you mentioned, Bogdana, that the urine won't really tell us where it's coming from. So I guess if the bladder is negative, we'll assume it's coming from.
Correct.
Yeah.
But we know that there are patients who have upper tract who develop non-muscle invasive bladder. We know patients who have bladder cancer develop upper tract. So there's always going to be that slice where it's unclear. Well, I certainly think that this was interesting, provocative, but this is phase 2 data. We're going to have a randomized phase 3 study right in this space. INDUCT 3 is going to open soon. And so they'll be looking to validate these results, which will be interesting.
To my knowledge, in the US, they are also planning a cooperative group study out of ECOG-ACRIN of neoadjuvant chemo.
And it'll be so important for all of us to enroll to this because, as we know, upper tract is so rare. So it took 10 French centers to do this for 50 patients. It's going to take a lot of involvement in US trials to get a decent number of patients on these trials. So please, please, please think about enrolling your patients in any and all upper tract trials that come your way. So Ben, you started us on this biomarker thought process. You mentioned ctDNA for bladder. I want to transition a little bit towards kidney and talking about the biomarker space in kidney. There was a whole really great session on it, talking about the lack of reliable biomarkers and the promise of future biomarkers. So can you take our surgeon-heavy audience and explain to someone like me, what is KIM-1 and why was everyone excited about it in Checkmate 214?
Yeah. For full disclosure, I'm super excited about it too. The underlying problem, and I think that's the best place to start this discussion, is that, as you very well know, as a surgeon yourself, you do an amazing job of, safely doing these partial nephrectomies or radical nephrectomies. But unfortunately, that's only curing roughly half of the patients. There's been a lot of different scoring systems, prognostic scoring systems that have been employed in the past. And quite frankly, I don't use any of them because they're all barely better than a coin flip. There was a nice study led out of Hopkins and the cooperative group ECOG where they took some negative adjuvant trials and then they applied, because you have well-documented, data in very specific, time cuts by doing this through a randomized study. And they looked at all these different, scoring systems, the Leibowitz, the UCLA, TNM, any of these. And the AUCs, right, the predictive capacity for this were only about 0.6, right? So barely better than a coin flip, which is 0.5. So I don't know. I don't find them helpful and I don't use them. But nevertheless, it's a challenge because we have an FDA-approved therapy for the adjuvant space. So, with pembrolizumab. So trying to understand who's going to benefit from that therapy largely hinges on, were you cured with surgery or not, right? If that's half of your patient population. So that's the issue that we struggle with in clinic right now all the time as medical oncologists, is how to use adjuvant pembrolizumab. And having a robust prognostic marker will greatly help us with that treatment decision-making process. So enter KIM-1. So what is KIM-1? It stands for kidney injury molecule number 1. This is a transmembrane glycoprotein that's been investigated by nephrologists for years before. And then Vincent Chu and some others, Laurence Auberger from France has helped, spearhead this work. But they've looked at this as a prognostic marker. Initially, that's what it was thought to be useful for, to try and understand, does the patient have microscopic metastatic disease or not? So Laurence originally published work from Emotion, which was a negative adjuvant atezolizumab study, but it seemed very prognostic. It was strongly prognostic for identifying those patients who were destined to have disease recurrence versus not. So the new data that was presented at GU ASCO just this past week was looking at this same molecule KIM-1, but in an entirely different data set. Here we were looking at it in the Checkmate 214 study, which was, as the audience I'm sure knows by now, ipi/nivo versus sunitinib. So again, we're testing this in a randomized phase 3 trial data set, and it similarly showed a very strong prognostic signal. The challenge, though, with biomarker development is that it's kind of like drugs and dosing. It's biomarker and cutoff, right? What's the cutoff that's used? Because you want to, avoid overtreatment, but still be sensitive. And, so on that particular point, the cutoffs that were used, et cetera, were different between these two different data sets and different analyses. So when I'm looking at this, going forward, it looks like KIM-1 really is going to be something that we're going to be able to use in clinic at some point. But I think because now we have a couple of large data sets showing it's strongly prognostic, the challenge will be the sort of next steps are what's the actual cutoff that we're going to be using, and how do we develop a CLIA certified test so that all of us can use it?
So to get back to your original problem setting in this space, because you're right, this is something that we face all the time, using adjuvant pembro, the only approved or the only, I would say, adjuvant therapy that has shown a benefit in the post-surgical space of all the ones investigated. Is there data coming? And if there is, I just don't know about it. So please inform me and our entire audience, looking at using KIM-1 in those trials and the adjuvant trials to see if it would have been able to demonstrate who was going to benefit from adjuvant pembro. Are we going to see that data at some point, or is it only going to come in future studies?
Oh, you mean is it already integrated in as a selection biomarker for future adjuvant studies?
Well, I don't know if it is. I'm saying, could you do an analysis like they presented for Checkmate 214 or for what Laurence Auberger presented for Emotion, looking back at the adjuvant pembro data? They have the correlatives, right? They have the blood. Are they going to run that analysis and tell us if KIM-1 is positive, give adjuvant pembro, that's the population that's going to benefit, or if KIM-1 is negative, don't bother?
Yeah, I mean, you highlight a really interesting point, because so far now we have two data sets, neither of which are pembrolizumab. But
correct.
Pembrolizumab is the FDA-approved drug. So it would be nice for them to publish KIM-1 data on that. I honestly don't know if they're actively doing it or not, but it would be really nice to see.
I think it also matters, and hats off to all these trials with the atezolizumab, because they are, I think, the most important negative trials, which lead to the most important discoveries, right? Emotion was a negative trial, but they showed this utility of KIM-1. Similarly, in bladder cancer, IMvigor010 was negative, but the ctDNA work that emerged was the most promising work we have. So to Ben's point, for a drug that is already approved, I don't know what would be the motivation to, show which patients are not benefiting, although it would be great to have that information.
Yeah, I love that cross comparison, Shilpa, because that negative trial biomarker work led to the ongoing modern cooperative group clinical trial, right? So we can learn so much from these negative trials.
And the IMvigor011, which was the prospective based on ctDNA. So yeah, I think the KIM-1 story is similar, and hats off to the investigators and the company to do that work from a negative trial.
So because I'm a medical oncologist, I'm always accused of being overly optimistic. So with that in mind, I am quite optimistic that in the next couple of years, we're going to have this KIM-1 molecule that will really help us better prognosticate patient outcome in the adjuvant setting.
I think it would be so
Question,
exciting.
just a naive question before we end. So is there any data on KIM-1 in healthy patients? I wonder if in the population-based studies, like we can certainly say, like, will this be also a biomarker for screening for kidney cancer at some point?
Yeah, that's a really good question. I suspect it's never going to be useful. Now, obviously, I'm not as much of an expert on the biology of KIM-1 as like Vincent Chu has been leading this from Dana-Farber, but my understanding of KIM-1 is that it's upregulated with any kidney injury, which is why nephrologists were studying it originally. So I think it's going to run into a specificity problem if we're trying to use it as a test. It'll be like our PSA dilemma in prostate cancer, but on steroids. So I don't think it's going to be useful as a screening test, unfortunately.
Okay.
But you're right. That's a huge need as well, because so many of these patients present with, pretty advanced disease. The best screening tool we've had, for better or worse, is, the ER and CT scans. So
yeah, imaging. And I think we have a really challenging track record with screening tests in GU, and as it is with PSA. But you're right. I mean, obviously, a good screening test and one with a good sensitivity and specificity profile certainly would be tremendously beneficial in the kidney cancer population. And I would say, honestly, to me, in the adjuvant setting, so much so, because we have pretty good data on localized progression, right, with surgery. And so really deciding who is going to progress from localized disease, who is going to metastasize, that's the space that we struggle with for sure. Well, speaking of metastasis and that struggle, let's talk about Cosmic 313, so the triplet strategy of cabozantinib, nivolumab, and ipilimumab versus placebo plus nivolumab, ipilimumab. So really looking at the addition of cabo in patients previously with untreated, intermediate, or poor risk metastatic renal cell carcinoma. So this was data that Dr. Albiger presented looking at the results of the secondary endpoint of overall survival, right? Updated progression-free survival and the safety profile. So Ben, do you want to tell us the findings and how they fit into the context of this disease space?
Yeah, unfortunately, this was, in my opinion, a negative study. Technically, it was a positive study because the primary endpoint was radiographic PFS. But the big takeaway message is that the data that we saw, there's no improvement in overall survival. There was this numeric trend that was favoring as strongly with PFS, and it was statistically significant, but there really wasn't much difference in OS. So the question is why, right? I mean, the big reason that we care about triplets is, there's a very high treatment failure rate with Ipi-Nivo, but it's curing some of our patients, which is like hugely exciting.
Correct.
But there's a 20% treatment failure rate with that. And we feel very confident about that number because that's what we saw in the original registrational trial for Ipi-Nivo. But also with this Cosmic 313 study, the control arm was Ipi-Nivo plus placebo. And there was a 20% treatment failure rate in that study as well. But cabozantinib definitely was leading to better short-term disease control, but it wasn't improving the long-term disease control. And I think in the discussion section, if you go back and watch the presentation and the Q&A afterwards, Laurence really highlighted this very well, I think, in terms of the big weakness for this trial, at least in terms of its study design, is that it was blinded, which made it very difficult to try and manage some of these toxicities. And so that led to a dramatic reduction in the dose intensity of Ipi and Nivo, especially Ipi, in the triplet arm that received cabozantinib, right? So like 20% of the patients only had 2 doses of Ipi, whereas in the placebo arm, 75% of the patients got all 4 doses. So, again, to, I guess, make a more apples to apples comparison, in the placebo arm, 75% of patients received 4 doses, but only 50% of patients in the cabo arm received all 4 doses. The main oomph of what we're trying to get out of this triplet, the Ipi-Nivo, was unfortunately compromised by adding the triplet. So I think this is an effort that's important. We do need better triplet therapies so that we can either achieve better durable responses that we are seeing some durable responses with TKI-IO combinations, just not nearly as many as Ipi/Nivo. But, so maybe some immune triplet in that way would be beneficial, but also some short-term benefit with Ipi/Nivo is needed so we don't have so many treatment failures. So triplets are the way that we need to go at some point because we have these distinct disadvantages with any doublet that you choose, but this is not that triplet. It's not the answer.
And so to get to that question, I want to push you just a little bit to make sure I understand. So you think it's that this is not the triplet, meaning it's cabo is not the addition, or do you think it's the fact that the patients didn't get as much Ipi/Nivo as they should have that didn't give you the benefit that you were looking for?
Yeah, I mean, when I was saying that, I was like giving the pragmatic answer. This is not the triplet because it's not going to get FDA approved because the data are just not there. Could this have been the triplet had they designed the trial better to help maintain dose intensity of Ipi/Nivo? Maybe, but nonetheless, cabo is a pretty tough drug, and it has some important overlapping toxicity with Ipi/Nivo, particularly GI toxicity. So when you're faced with that patient, it can be challenging to figure out, is this typical expected GI toxicity from cabo, or is this immune colitis? So ideally, what we're looking for is a drug that doesn't have that same overlapping toxicity. Hence, a lot of us are pretty excited to see the data from the Merck study that's completed enrollment where they're using belzutifan as their triplet drug. Not with Ipi/Nivo, but they have their own CTLA-4, PD-1 combination with durvalumab. That should have a lot easier use in terms of toxicity management. So we'll see.
That's so funny because I have to say, I've never thought about the fact that it's actually beneficial if all of your drugs have a different toxicity profile. Because I would inherently, as someone who's thinking of it from a patient perspective, that sounds horrific, right? You're going to get hit from every single organ system. Why would you ever do that? But I understand your point that when the toxicity profiles for these drugs are similar, you don't know how to dose reduce one or the other and which one is causing the problem. That's a unique challenge. I've never thought of it that way. Thank you for pointing that out.
Yeah, from a patient quality of life, I can see your point. If you're adding unique toxicities, then it is making it challenging. But if they're overlapping toxicities, not only does it make drug modification challenging, but it also oftentimes leads to capping or inappropriate dose intensity because now all of a sudden you have like such severe anemia or such severe infection risk that you have to modify the doses of the two agents, or three.
Absolutely. I think this has been a fantastic discussion with the two of you. I'm so grateful for your time. I'm so grateful for the opportunity really to share the highlights from this conference with our audience, because I think it's great to see more and more inclusive conversation across the multidisciplinary landscape that we're seeing at GU ASCO. So we had a lot of talk about surgical therapy with prostate, in bladder, and less so in kidney this time around, but that's okay, it'll change. And the need for multidisciplinary cooperation and the way that we present the landscape to our patients, it's going to keep evolving. It's going to continue to evolve to be more interdisciplinary. I think there's no way that we're going to go back to being more siloed in the way that we treat these patients. So it's such an exciting time. I'm so grateful for your insights. Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.